So good morning and thank you very much. Today we're going to be talking specifically around syphilis prevention and treatment. And I'm going to be drawing from two different very recent guidelines. So in August of last year, the Department of Health brought out a guideline for vertical transmission prevention, and they specifically cover syphilis in that section. And then very recently, within the last month, hot off the press, the South African HIV Clinician Society has brought out a guideline for the clinical management of syphilis. And what's amazing about this guideline is the group of people that got together to write it. So they literally included infectious diseases, obstetrics and gynecology, pediatrics, ophthalmology. They had the most extraordinary multidisciplinary team that actually gave input. So the question, of course, is why now all this sudden flurry of guidelines in the last 6 months? And the issue is not just South Africa. We have seen a global uptick in syphilis cases, and specifically a rise in syphilis among pregnant women, which is where actually the problem lies. So congenital syphilis is, we'll talk a bit about that today, is a very challenging illness in our little ones with a very high mortality. And now as you can see there, that's South African statistics there, how we've had an increase of the prevalence of syphilis in our pregnant women. I think part of the reason why this has been happening is there's, of course, all the normal sexual health stuff, but there's also been a global shortage of parenteral penicillin over the last few years, which means we haven't been treating syphilis as well as we could have. And so the WHO has brought out a commitment, and South Africa has signed up to that. And you can see that date feels a little bit ambitious, but we have committed to try and eliminate congenital syphilis by 2028, which is literally 5 years around the corner. So to be able to do this, there's two parts to that. The one part is a really intensive screening and treating of our pregnant women during pregnancy, and we're going to talk a bit about that. And then, of course, just generally looking at the rising burden of syphilis in the country. So getting really good with our STI services, for example. That's not always happening when we're doing syndromic treatment, that we're routinely checking for RPRs, for example. So there's much more of a focus now and really also decreasing the incidence in our normal population. So for this guideline, there are specific populations that has been identified as risk. And similarly to the HIV, our adolescent girls and our young women, not always so good at condom negotiation. So there's a high incidence in those groups. Of course, in our female sex workers and our men who have sex with men and transgender people, mainly because they're struggling to access services due to stigmatization and discrimination. Pregnant women, people living with HIV, obviously also a high-risk group. And then any patient that you see in your practice that presenting with a discharge, you need to consider whether syphilis might also be on board. So let's just remind ourselves of the pathogenesis and the clinical manifestations of syphilis. And these are two different graphs that shows us that progression. The top one is from the Clinician Society. The bottom one is from the Department of Health guideline. And all I want to show on this, because we're going to go into it in detail, is that there's an early syphilis phase, which is when we see the primary and the secondary syphilis. And remember, primary and secondary syphilis all happens within the first 3 to 6 months of getting infected. So secondary syphilis is not something that happens sometimes later on. It's all part of that initial illness. And then you go into a long latent phase. There's an early latent phase and there's a late latent phase. We'll speak about that as well. And then eventually 10, 20, 30 years down the line, if you've never been treated, you can develop tertiary syphilis. But let's just look at those different groups in a bit more detail. So what do we mean when we say primary syphilis? So primary syphilis is actually just a little ulcer, and it's actually where you got inoculated by that syphilis organism. It's where it got into your body, and it forms a little primary ulcer, which we call a chancre. And it's about 3 weeks after exposure that you might have that little ulcer, but it can be anything from 10 days to 90 days. So it can be a good 3 months after exposure. It heals itself within 4 to 6 weeks. You would not even know that you've had it. And because it's quite small and it's not painful and it's on the genitals, you might not even know that you've had an ulcer like that, or you might just ignore it as, oh, well, hopefully it'll go away, and then eventually it does. So a lot of people do not present at our facilities with these. Okay, so for those of you that are a little bit sensitive, there's some very gruesome pictures about to come up. So we're going to start just looking at what this looks up. So please close your eyes, trigger warning. So this is our actual little chancre, what it looks like on the genitals. And it starts off actually as a little nodule. and then it becomes this little firm indurated between 0.5 to 2 centimeters. And important, it's usually painless. The problem is that it can look, it's not always that simple. So you can also, you can have it on, not just on the genitals, we can also see it in the mouth and the rectum. And look, you can even have it on the finger. So you can also get inoculated on a finger, and you might end up having a little chancre on your finger. So just to keep that in mind. But you also can have presentations that might not be so typical. So for example, you can have multiple ones. You can have ones that's confluent. They call that a kissing ulcer, when it happens within the fold of, for example, the buttocks. And they can also be painful, especially if they get a little bit infected. So the rule is, don't try and look at an ulcer and go, oh, I think that's a syphilis ulcer, or no, I'm sure that's not a syphilis ulcer. Do your RPR to double check. So you also can get oral syphilis, and these are not so easy to differentiate, for example, from a normal actus ulcer. So lots of people have little ulcers in their mouths. And look, 30% of syphilis is actually acquired through oral sex. It can be on the upper limb and the tongue more often, but it can also be on the palate and the buccal mucosa. And again, it starts off with a reddish papule, and then it can cause like an ulcerative lesion in your classic primary syphilis, and also you can have multiple ones. But you can also have ulcers in secondary syphilis. And then it's got more of this grayish white and mucus patches. But again, you're not going to be able to look at an ulcer and tell which is which. So your primary syphilis is now started early on, within that first 2 or 3 months. Then it all settles down, the ulcer goes away, you forget about it. And then within 3 months of that initial infection, you can actually get that secondary syphilis. So it happens very quickly. And it resolves also again itself within 3 months. And it will look completely different in different people. So there's lots of different ways in how secondary syphilis can present. They call it the great imitator. And I'm going to show you lots of pictures of secondary syphilis. And you will see that it looks just like just about every rash that you know. And so what quite often happens is people either ignore it. Again, it's not very bad, so I'll just hope it goes away, and then eventually it does. Or it might be that you did go to your doctor, but the doctor thinks it's something else, and you don't actually get treated for your syphilis. So also notice that primary syphilis can take 3 months to present, and secondary syphilis presents around, so you can actually have them all at the same time. You might not even have had a primary ulcer, and then you actually have both primary and secondary at the same time. So let's look at some pictures. So the classic one, this is always the textbook one, is this non-specific generalized mucocutaneous rash. And quite often it will be accompanied by having like flu-like symptoms. So you have that little bit of malaise, of muscle ache, you'll have some glands up. You can easily mistake this with a lot of sort of viral infections. And then sometimes you can get some very weird and wonderful, what they call these annular plaques. Classically, you can see it's darker in the middle and then sort of a ring around it. These annular lesions, that's very classical if you see them. They also have what they call ham-like papules. You can get magules, you can get mild mobiliform rashes. And then in some cases, and especially in our people living with HIV, some of these lesions might actually become necrotic, and then it almost looks like a vasculitic picture, and we call that malignant syphilis if they become infected like that and start crusting and scaling. The classic thing also that's very typical of secondary syphilis and might make it easier to spot is the fact that it's one of the few rashes that you see on palms of hands and on soles of feet. And again, it can just be a mild macular rash like that, or it can actually make small papules. You can look at that sole of the foot. You can easily confuse that for a fungal foot infection, for example. But it's also one that can typically affect the scalp. So they call this looks like a rat's been nibbling at your hair. And you can actually get quite severe crusting in some patients where it actually will look like a seborrheic dermatitis, for example, and you might be going down the seborrheic dermatitis route, and meanwhile it's alopecia because of syphilis. Then all of us has heard about condylomata lata, which is in about 10% of our secondary syphilis patients will have some condylomata lata somewhere. And they're warts. They're warts caused by syphilis. They're flatter than the typical HPV warts. I've got another picture on another slide. The trick with condylomata lata is that it's always in moist areas. So if you've got like genital warts that's going all down the thighs, that's probably just going to be your good old-fashioned HPV. But if it's in that moist areas, inside the mouth, inside the anus, inside the vaginal area, then it could be syphilis and you need to go and look for it. So they call syphilis the great imitator, and all the pictures I'm going to show you now are all syphilis pictures, but you'll see that they look like all kinds of things. So that was a description of a very psoriatic looking rash in a patient that turned out to be a syphilitic rash. You can get papulonodular lesions like that in your advanced HIV patients can be very confusing, can even look a bit like Kaposi's. You can have something that looks exactly like urticaria, like an allergic rash, but it doesn't itch. So that's one of your clues. This is just an example of a comparison between your HPV warts and then your condylomata, your syphilis warts. And although the condylomata ones are slightly flatter, and in moist areas, again, without actually a syphilis test, you won't actually be able to tell the difference. Look at those ones. That actually looks like ringworm or a fungal infection. It's got that central clearing. I wonder how many ringworms we've treated that might have ended up actually being secondary syphilis. And that was an example of a pemphigus-like. So also, again, in advanced HIV, you might be thinking about histoplasmosis or some of your more weird and wonderful fungal infections. And all of these are syphilis. So I think the main message is there's no rash that's going to go and come with a flag and say, this is secondary syphilis. You need to have a very high index of suspicion. So part of secondary syphilis, often when we think about the neurological, sort of the tertiary syphilis pictures, we tend to think of people who've had syphilis late in life, but actually neurological complications are also seen as part of secondary syphilis. And we see it especially in our HIV positive patients. So this can occur several weeks after that initial infection, and it's got two different presentations, either as a syphilitic meningitis. So they come in with that classic meningitis picture, and they can also present with seizures, but they can also present with cranial nerve pathologies. So that is why whenever you do an LP, always important to send your CSF off looking for your syphilis, but also to consider it in some of your cranial nerve things. The other presentation, which is a little bit less common, is that you can actually have a stroke from some syphilis. So especially if you've got a young person who's having a stroke, it might be good to put that as part of your investigations. And you also can get a spastic paraparesis, where actually the meningomyelitis also caused by syphilis. And then to make it even more complicated is you can also get various ocular manifestations. And that can be both during the secondary and the tertiary phases. And you can get just about every type of eye affectation known to man. So patients might present either with a sore eye or a very red eye. They might have floaters. They might have loss of vision. So anybody you see that's got ocular inflammation and got a red eye, that's not your classic conjunctivitis, even your classic conjunctivitis, it might be a good idea just to do your RPRs. So the most common is actually a posterior uveitis, but any part of the eye can be affected. So here on the top, you can see that was an anterior uveitis caused by syphilis, just a classic red eye. And this very severe, this was an AIDS patient who had very severe retinal damage. You can see the second funduscope picture there is actually after treatment, where he was left with some scarring and damage. So again, when you see eyes, think about syphilis. So once you've had your primary and secondary, so you've had that acute infection early phase, that's all going to happen within 3 or 6 months. If it hasn't been treated, we haven't picked it up, now it's going to go latent. And we identify two different parts of the latent phase. The first one is the first 2 years of the latent phase. So that is in that first 2 years, because you're still very infective during that time. So you're asymptomatic, but you can spread the illness. But after 2 years, the organism goes quite dormant, and it's going to lie very dormant, and you're not actually very infective until you eventually develop tertiary syphilis. So yeah, sexual transmission is uncommon during this latent phase, but the problem is that we can't tell when you've got a patient in front of you, if they're asymptomatic and they're RPR positive, you can't tell if they're in early or in latent phase. So we treat them all as if they are very infective. It's also interesting to note that you can get secondary syphilis twice. So you can have a rash that then goes away and sorts itself out and comes back again. So it's not that it's just a one-off event. So about a third with that latent syphilis will eventually develop tertiary syphilis, which can be a few years up to several decades after that first infection. Tertiary syphilis, we don't see this very much at all. Hopefully most patients we would have picked up at some stage that there's a problem and would have treated them. But that's mainly a picture of progressive dementia. So they've got all these neuropsychiatric manifestations, personality changes, depression, psychosis. And you might have some patients who present with tremors or dysarthrias or ataxias. So in our very elderly patients that develop weird syndromes and dementia, it's always just good to double check that. This is a gumma, that's syphilitic gumma, which is also one of that tertiary phase manifestations. And then the typical thing that we always hear about tabes dorsalis, but we almost never see that. And that's a progressive spinal cord disorder where they develop areflexia, ataxia, incontinence, lacerating pains. And again, in sort of your more older people developing weird symptoms in their legs, neurological symptoms, always just double check for your for syphilis. Very important is that it's especially your HIV patients that's going to have these very atypical presentations or are more likely to progress. So great. So what is some of our diagnostic principles in terms of diagnosing syphilis? So there's actually quite a few different test options, and I'm going to highlight what we obviously have in the NHLS. The first one that is sort of key in terms of being very specific for syphilis. If this is positive, we know that the patient has had now either syphilis now or in the past. And this is an antibody test. We classically in the NHLS, we've got what we call the TPHA or the TPPA, and private or on our CSFs, they do that FDA ABS, and you can even do in private IgMs and IgGs. And this has got a very high sensitivity. So if it's negative, then you know, okay, this person has not been exposed to syphilis. The only problem is it's not very good at picking up primary syphilis. So it can take about 3 months to actually go positive. So if you've got somebody with an ulcer and you're not sure if it's syphilis or not, a TPHA is probably not going to help you to make that diagnosis. Our non-treponemal tests is classically either the RPR or the VDRL. And again, in our context in the public sector, it's mostly the RPR. And then in private, and I'm not sure if we will have that also available, hopefully in public sector, is the NARTS. So these are PCR tests that is specific for treponema pallidum, so very, very specific. And this is particularly something which you can take a swab. So typically either from an oral lesion or from an ulcer, and you can send that swab away, and we'll look a little bit at and which context you might want to use that. So just to emphasize, your TPHA test, because it's an antibody test, will tell you whether somebody's got syphilis at the moment or whether they might have syphilis in the past. If they're TPHA positive and the RPR is negative, we all sort of normally assume it just means they don't have an active syphilis infection at the moment, they have had syphilis in the past, but just watch out that in the latent, it's also possible that the RPR might be negative. And also in that early primary syphilis, your RPR might also be negative. So it's not quite so straightforward. So what the labs do at the moment and how the algorithms work is most laboratories will start with a treponemal test. So if we send, you'll see on the NHLS form, there's a little tick box for syphilis. You just tick that. And normally they will do that TPHA first because that tells us whether there definitely has been syphilis exposure. And then if that's positive, then they will do the RPR to confirm whether there is active replicating infection at the moment. So it's quite exciting, and we'll discuss at the end whether these are in the Eastern Cape yet, but the part of the vertical transmission prevention guideline is introducing regular testing during pregnancy, and they've introduced a rapid diagnostic test. So that's a point of care test where you can test for syphilis, and just important to understand that it's testing for antibodies. So it's similar to the TPHA tests, and it's not an RPR test. So we're not doing RPR point of cares. We're actually doing TPHA point of cares when we have those available. So I'm going to talk a little bit about treatment principles, and then we're going to actually work through all these different phases and how we manage each of those. So our treatment of choice is penicillin. It's actually quite extraordinary that penicillin that's been around for 80 years now, and there's almost no resistance to penicillin. So that's quite extraordinary. So it's a great drug to use. We use Ben-Pen, which is a intramuscular long depot preparation. So that's why you only need to give one injection quite often. It's got a 90 to 100% success rate. And then when you do see treatment failures, it's not because there's resistance, but it can be, for example, things like in people with HIV, it's got a higher treatment failure rate on penicillin. You can also use penicillin G, but penicillin G is an intravenous preparation. It's short acting, so you have to give it every day, usually for about 10 days. And then just to note that your pen doesn't adequately penetrate the blood-brain barrier, so we can't use that for neurosyphilis. So we would normally use our pen G, and I will go through the exact preparations for that just now. So what do you do if somebody tells you, they're allergic to penicillin? And I think it's important to realize that there are actual severe penicillin reactions are very rare. So please have a decent history and just find out. A little bit of a rash on amoxicillin at some point does not count as a penicillin allergy. And because pen is by far our best option, especially in our pregnant women, we need to, and we might need to make an effort to see if we can get that penicillin on board and even consider desensitization. If you can't use penicillin, doxycycline is a good second choice for non-neurological syphilis. And early syphilis, usually 2 weeks course. If it's very latent syphilis, those are the ones where the RPR has gone negative, then you would usually give for 4 weeks. But the problem with doxycycline is it's contraindicated in pregnancy, which is where our main focus group is at the moment. You also have the option of the cephalosporins, and remember, there's not many really true cross reactions with penicillin allergy, so you can use a kef if you're penicillin allergic. And the cephalosporins becomes important for neurosyphilis because doxycycline does not cover that blood-brain barrier as well. So if you can't use pen, you're going to end up using kef. And again, I will run through the details when we talk about neurosyphilis. Just to watch out, azithromycin actually does have a lot of resistance, probably because it's part of our syndromic treatment, and therefore it's not a good cover for syphilis. And they've tried a little trial in linezolid, and that's also not useful. So now we're going to go a little bit more practical in terms of the kinds of scenarios we might see in our practice. And we're first just going to talk about primary and secondary syphilis. So these are people who are symptomatic. It's in that first 6 months. Sorry, I didn't warn you about the pictures, more pictures. And this is anybody now who's got a highly suspicious ulcer on the genitals, mouth, and the finger. And what you want to do on all of those patients is to start doing some serological testing, and our lab will usually do that TPHA and baseline RPR titer for us. But important with the primaries to remember is that if the RPR comes back or the serology comes back negative, so the TPHA and the RPR is negative, and you're still very suspicious about syphilis, just repeat it, because there's a good chance that that antibodies is just not developed yet. What would be ideal if we had that available was those knots, and if you could actually take a swab of that ulcer, you can take a swab of the ulcer, and in private, they send them for T. pallidum as well as your herpes virus 1 and 2. So then you can at least see which one of the organisms is causing the trouble. For secondary syphilis, so as I've now said, we've got all these very suspicious rashes we're going to see, and we're going to wonder maybe that's the syphilis. Again, very easy. You're going to send them for your TPHA and baseline RPR. And to note that anything that's in moist membranes, so your condylomata lata, your genital ulcers, your oral lesions, then you can do those knots. And this would be a great place to have those knots available to confirm that we've got T. pallidum in those areas. And we generally don't biopsy to try and diagnose syphilis. So you'll use a suspicious rash plus your serology or plus your knot. You might sometimes end up biopsying a region that was actually syphilis because you haven't done your RPR, but we don't do biopsies to make a diagnosis. So again, the treatment of primary and secondary syphilis. And what's interesting is that this primary and secondary syphilis responds extremely well, very, very high cover on a single injection of pen. So I'm thinking we're so used to treating the latents with that 3 injections over 3 weeks that we forget that actually all it needs is 1 injection. So if you look as well, for example, in our syndromic treatment guidelines, if you're treating genital ulcer syndrome, they literally only need that 1 injection of pen because you're actually treating symptomatic disease. If you can't use your pen, and if they're not pregnant, then you'll use your doxycycline, and a 2-week course will be enough for that. So now latent syphilis. So remember, I've said there's that latent period before the first 2 years for early, and then after 2 years for late. And you might find that you discover that somebody has, this is mostly going to be opportunistic screening. There's not going to be it might be that you've got a pregnant woman that comes in, or you might be treating a partner of somebody or a pregnant woman that's been diagnosed. And then you're just going to send your normal yellow top tube for a syphilis screen. They're going to do your RPR and TPHA for you. And generally how we interpret those is mostly if they're asymptomatic, so there's no symptoms, they're TPHA positive and RPR negative, we will all normally assume there's a past syphilis infection and there's nothing, no active infection at the moment. But if they're TPHA positive and RPR positive, it's now very difficult to differentiate whether they've got early or late latent syphilis. So we manage them all as if they've got late, and this is where you do want to give extra cover because the syphilis is very slowly reproducing, and so therefore you might miss some of the organisms, and so we treat them all with that weekly injection for 3 weeks that we all know so well, and that's with that pen. So neurosyphilis and ocular, I'm not going to go into too much detail because we do not have quite enough time. But also you're going to see very few of these patients. It's just to sensitize you when to think about it and to know what's in the guidelines, so that if you, those of you that might be in a ward setting or district hospital, that you know what you need to go and look up in these scenarios. And the question is a little bit, in which of these scenarios would you do a lumbar puncture if you've got somebody that's got confirmed syphilis? So you've got somebody that has an RPR that's positive or a TPHA that's positive. And obviously, if they've got any signs and symptoms of meningitis, there we go. So if you're going to have any signs and symptoms of neurosyphilis, then obviously you need to do that LP, and then you're going to check on the LP as well, whether there's actually any T. pallidum on the LP. But if you don't have an LP, if you're in a scenario where you can't LP that patient for some reason, if you've got a positive RPR and TPHA and you've got signs, meningitic signs, you definitely want to add in penicillin into your regimen as well. What's quite interesting is that asymptomatic neurosyphilis, so this is somebody who might have syphilis in the CSF, but they're asymptomatic otherwise. So they've actually got some secondary syphilis, but they're not very sick. That might be one of the reasons why somebody's not responding to treatment. So one of the indications of somebody who's got very high titers or titers that are rising might be that, and you can see they've got the syphilis on the blood is just not responding to your treatment. You might have to do an LP and just check that they might not have asymptomatic neurosyphilis. So that's quite an interesting learning point. And in anybody who's got tertiary syphilis, so that's cardiovascular syphilis or ocular syphilis, or even if they've got peripheral neurovascular things, 30 or 40% of them will also have tertiary syphilis. And so we would want to LP all of those patients as well. But that's your only indications for LP. So that's for somebody who was syphilis positive. Now you might have somebody that's RPR negative. So if somebody has got RPR negative and they've got a negative TPHA, that rules out neurosyphilis. So you don't need to do an LP in that particular patient. But if they're RPR negative and TPHA positive, as I've mentioned earlier, you might have a scenario where in late neurosyphilis, that RPRs might actually be negative. And so you would consider an LP in those patients as well. Ocular syphilis, we treat similarly to neurosyphilis, so you don't actually need to do an LP. If you've got ocular symptoms and you've got a positive neurosyphilis test, then you can just treat. When you're looking at your CSF, so this is quite interesting, is that if you've got a TPHA, if your TPHA is negative on your CSF, that actually excludes neurosyphilis. But if you've got a positive TPHA, it doesn't mean it's active neurosyphilis. That's a bit confusing. And then you're going to do your RPR. And if your RPR is then positive, that's going to confirm that neurosyphilis. So you need a positive TPHA and a positive RPR to actually confirm neurosyphilis. Increased lymphocytes might also be helpful, and elevated protein might also be helpful. And it is possible to have neurosyphilis and not necessarily have a positive test on CSF. So you might have to retest and have a high index of suspicion. So how we treat these people, so as I mentioned, pen can't cross the blood-brain barrier, so you're going to use penicillin G. And those dosages you can look up if you have a patient like that. But if you can't use pen G for some reason, for example, the patient is allergic to penicillin, then ceftriaxone is going to be your other option. Or if you can use procaine, penicillin, and probenecid, depending on what you have available in your facility. Just a couple of words about steroids. So there's no scenario in most primary and secondary and neurosyphilis to use steroids, either in the treatment or the prevention of a reaction. But we do use that in ocular syphilis. So with ocular syphilis, with anterior uveitis or interstitial keratitis, you can use superficial ones. The other ones, you can use systemic ones, but we'll leave that to the ophthalmologists to sort out when they see these patients. Now let's get to some things that's really going to affect us every day in our clinics, and that's particularly managing the pregnant mother. So this is from the guideline, the National Department of Health guideline, and the big change has been that we are now screening women regularly. So as soon as they book, we're hoping women will book before 20 weeks. Early booking is important. We will screen them at every single visit. So all the bump visits, 20, 26, 30, 34, and 38 weeks. We need to screen them when they're in labor. So similarly, when they're coming for labor, just like you do your HIV test, your viral loads, you will do your, you look for syphilis. Any patient where there's a uterine death, we need to test the mom and send that placenta for histology. And of course, anytime the mom is symptomatic, you're also going to do the test. So you'll have to have we have to be doing these tests very, very often. So what they have is now these rapid tests that I've mentioned, and there's even a dual one where you can test syphilis and HIV on the same drop of blood. I don't know if we have these available yet, but it's just to emphasize that this is a TPHA test. It's an antibody test. So say, for example, at 20 weeks, her first rapid test, point of care test is positive. That means she's got antibodies. It doesn't mean she's got syphilis, but it means you can't now use that rapid test throughout her pregnancy to screen for syphilis. It's going to be positive every time. So if the first one is positive, you're obviously going to confirm. We'll go through the algorithm in a minute, but you'll be having to do actual RPRs you're going to send to the lab to screen her for the rest of her pregnancy. And although the rapid test gives us a clue, remember the TPHA only tells us whether somebody's been exposed, you now have to send an RPR test to the NHLS to confirm. And I'm going to run through the two different algorithms that's in that guideline. So this is in the guideline for vertical transmission, and this is when you've got that rapid test. So remember, this is a TPHA test. This is also assuming that our NHLSs are, this is the real resource-restrained version of doing it. So if your rapid test is positive, then you're going to give your lady your first dose of penicillin, of that Ben-Pen. Then you're going to send an RPR to the NHLS. And look, they've got this lovely thing here that if you're going to do a little note on the NHLS form, and you're going to say that if the RPR titer is 4 in 1 or less, that they must also please repeat the TPHA test. I think in our labs, they automatically repeat the tests, but you may need to make a little note. They might not repeat it if the RPR is negative. So then it might be sensible to confirm your, so if the RPR is negative and the TPHA is both negative from the lab point of view, then this patient does not have syphilis, and you're just going to continue your regular testing. And now you can still use the rapid test. It means that was a false positive on that first one. If the RPR is negative from the lab, but the TPHA is positive, so now repeated by the lab, it means that she's probably been exposed in the past, but there's no active syphilis at the moment. You're going to regularly test her, but remember she's got a TPHA, so every time she comes in, you're going to send the blood to the lab. And if they're RPR reactive, you don't even need a TPHA because you've already got the TPHA that you've done in the clinic. That's a patient that's syphilis positive. So on that visit, when they come for their result, they'll get their second Ben-Pen. And then you're going to bring them 1 week later back for their third Ben-Pen, and then they would have had their full course. So if we have that available, this is very nice. In our setting, we might be sending bloods to the lab. So that means you're actually going to be sending bloods to the lab every time the patient comes in. You're sending an RPR test if your lab does not have both. And again, you're going to ask them that if the RPR titer is 1 in 4 or less, to please just check that TPHA again. If the RPR is negative or it's got a very low titer and the TPHA is negative, we're not going to worry, and we're going to again test her every time she comes in. If the titer is again negative or less, but she's TPHA positive, we're actually going to treat these patients. So these are the paranoia about the latent that we've mentioned. So in pregnant women, we are very paranoid about possible transmission to babies. And so we are over-treating this particular population. And that's a little bit different from our non-pregnant lady people. But anybody who's got an RPR titer of 8 to 1 and more will definitely be treated. And we don't even need to do a TPHA. On top of that, we will treat all of them. So our treatment in pregnant women, very easily, we're going to do those 3 weeks. Remember, they're asymptomatic. We don't know if it's early or late latent phase. And so it's 1 injection once a week for 3 weeks. If they're allergic, you can't use the doxycycline. And so the guideline actually says you're going to refer them to the hospital for penicillin desensitization. And one of the things you will do in that scenario is you will have a real in-depth look on whether this was actually a proper allergy or whether it's something we can actually challenge. So very important in pregnant women is that it doesn't help, treat the pregnant woman and then she gets reinfected by her partner before the next visit. And so in terms of adequately treating your mother, you also have to adequately treat your trace and treat your partners. So all recent partners, so partners within the previous 3 months, you're going to treat regardless of their serology. So you're going to do a baseline RPR because we're going to use that for follow-up, but you're going to treat them even if the serology is negative because they might be in that primary window period. So we're being very current. If they are RPR positive and they're symptomatic, then that single injection is fine. Then a single injection is fine. And you can use your bent pen or your docs. If they're positive and they're asymptomatic, then you're going to send your TPHAs and your confirmatory as we normally do, and then those people will also treat for 3 weeks. So it's very simple. If the partner is symptomatic, you can do the 1 injection per. If the patient is asymptomatic, then you're going to do your 3 weeks in a row. So once you've treated, so say you've had a pregnant woman and you've treated her, she's had her 3 injections, you need to follow up to make sure that you've treated her adequately. And that RPR gets done at 3 months. So 3 months is the magic number by which time we expect that RPR to be recovering. And we're expecting that 4-fold drop in the titer. So you want to have a baseline titer. So you can see, for example, if it was 1 in 32, the titer, you want it to drop to at least 1 to 8. What's important to notice is that if the titer is low, for example, a 1 in 4, they're not going to obviously drop in 3 months. And you can get low titers that persist for years. So low titers that stay the same, we ignore. But if the titer starts going up, that would be a concern. And very important, if you're currently treating somebody for syphilis during their current pregnancy, it doesn't help to then retest them for syphilis because it takes quite a while for your RPR to actually go negative. So there's no point in them now doing ongoing RPRs. So congenital syphilis is one of those topics I do not want to cover in detail. It's a very complicated field, and it's more to synthesize you which babies we're going to look for, and these babies need to be referred. The risk of transmission is actually highest when somebody's got primary and secondary syphilis. There's much lower risk if you are latent. But as I say, we don't know when people are early or late latent, but also we've got so many women that has potentially syphilis that there's actually quite a lot of congenital syphilis still as a result, even though the transmission rates are low. And there's a very high mortality rate for your congenital syphilis. So you can see that placenta there can be a large, pale, greasy, so that can already be a clue if you're a midwife and you're delivering the baby. And the umbilicus, they've got something which they call the Barber pole appearance, where it has these spiral red and blue stripes due to a necrocyting funicitis. So early congenital syphilis, I'm not going to run through all the symptoms, but basically any baby who is obviously quite ill, and what they have in the vertical transmission guidelines, which is easy, is they just got these red flags to look out for. So if a baby is born who's been exposed and they've got any respiratory distress, any signs of liver dysfunction, any petechiae, any thrombocytopenia or anemia, or any suspected meningitis, they need to immediately be referred to a high care or an intensive care unit to be looked after. I just want to make a note. So there's 2 types of congenital syphilis. There's the one before 2 years, the one that happens quite soon after birth. But just to be aware, there are ones that gets missed and only presents after 2 years of age. And they usually have kinds of funny bones and funny teeth and funny noses. So that's just to keep in mind in our pediatric clinics. If you've got a child who's got strange changes on X-ray in terms of the bones, this thing called a saddle nose and funny looking teeth, to also consider that might be late syphilis. So if you've got a baby where you're considering syphilis, the problem is the TPHA is not helpful because it crosses the placenta. So you can't do a TPHA to diagnose syphilis in a baby. So RPR is our first line testing. And normally what you're looking for is that the baby's RPR is 4 times higher than the mother's RPR, but even that's not that definitive. So you're also going to look at the treatment history of the mother. You're going to look if there's signs of congenital syphilis. So you have to take sort of the whole picture into consideration. And what's probably the most helpful is also sending that placenta for histology to get confirmation of that. So when you assess your babies, again, I don't want to cover that. It's just to show that the Department of Health guidelines, basically, you're just going to do full blood counts and LFTs. They don't recommend that you need to do X-rays and LPs. The HIV Clinician Society, if you can do X-rays and LPs, there might be times when you could do that. But again, you will look that up if you have a child like that. So what's more important is being able to identify the asymptomatic baby, especially whether this baby has been exposed or not. So you're going to have to look at, you've got a mother who's RPR positive or was RPR positive during her pregnancy. How do I decide whether this baby is actually exposed? So firstly, if the mother did not have her 3 weeks of treatment, so she did not complete her 3 injections of Ben-Pen. If she had her 3 injections, but there was more than 14 days between 2 injections, so that's also considered not adequate treatment. If her last dose was less than 30 days before she delivers the baby, so you're going to have to look back and look at when was she treated. If it was very recent, we would still consider that an exposed baby. If the mother obviously had incorrect dosing, if the mother did not receive any treatment at all, and if she was not treated with penicillin for whatever reason. So in any of these scenarios, we would call that a baby that's where the mother's been inadequately treated. So how the treatment works. So if you've got a baby who's asymptomatic, but the mother was fully treated more than 30 days ago, then you don't need to give anything to the baby. Easy. If you've got a baby who's asymptomatic, but they've been exposed, so all of those criteria that I've just mentioned, not treated, poorly treated, etc., then you're going to give the baby the Ben-Pen preparation, the 50,000 units. Remember, you can't give it IV. And that's the intramuscular injection in that little baby as a post-exposure prophylaxis. Okay, so that's something we need to be able to routinely do when we're in our midwifery units. If you do have a baby with congenital syphilis, please note it's a notifiable condition. You're going to admit those babies for 10 days, and they're going to be treated with Pen-G and with cefotaxime, depending, and the dosing will depend on their ages, and you can go and look that up if you've got a baby like that in your district hospital. Any baby that's got a positive titer, whether symptomatic or asymptomatic, you're going to have to follow up to see whether that titer recovers. So that's usually at the 3-month visit or the 14 weeks immunization visit. And again, you're going to look for that RPR to drop by 4 times. And very important, these babies need regular neurodevelopmental screening. In the vertical transmission guidelines, I recommend 20 weeks, HIV Clinician Society at every meeting, every visit. Great, we are almost there. We're now just going to talk about what we do with RPRs that doesn't respond to treatment, obviously important. So firstly, what do we do with people who fail to complete their treatment? So now you've got somebody, you've started them on their injection. At which stage do you? So if somebody is coming back a week or 2 late for their injection, as long as it's less than 14 days, you can just still give it and continue and finish the course. If they've missed more than 2 weeks between their 3 injections, then you have to start the course all over again. That's simple. If you've got somebody that they had 1 injection and then they vanished off the grid for 6 months and now they're back, if you've got a pre-treatment RPR, then actually you can redo the RPR. And if you see, no, actually they responded fine to that 1 injection, then you don't have to treat again. But otherwise, if you don't have that, you might have to just treat again. We don't know what to do if you interrupt doxycycline. They're just saying healthcare worker discretion. So you will look at the scenario and decide what you want to do. So very important to get those baseline titers. And when you do take a baseline titer, do it on the same day that you're giving the treatment. So if you've got a patient and you pick up that the titer was done a week or 2 ago, and you're going to give Ben-Pen today, take another titer because the titer might have changed in the last 2 weeks. And we're going to monitor how well this injection impacts on that titer. So you need a titer that's on the same day as you giving the Ben-Pen. So I don't think that's something we're not always very aware of. Then you're going to do serial RPRs to check whether your person has responded to treatment. So for early syphilis, so that's usually our symptomatic guys, we expect that RPR titer to reduce by 4 within a year. So we expect a good response within a year. And so you're going to usually repeat your RPR at 6 months and 12 months. So in pregnant women, we will do it 3 months because we're a little bit paranoid. But in our other population, you can just do it at 6 months and 12 months. But if you've got somebody that might have late syphilis, you're going to actually take a good 2 years for that RPR to fall to reduce completely. And you're going to therefore check at 6 months, 12 months, and 24 months to make sure that that RPR titer has come down and that it has stayed down. So again, the way you do that fourfold is you just take that number, the 1 in 64, and you divide it by 4. So with neurosyphilis and ocular syphilis, you only need to do the serology RPRs. You don't have to do repeated LPs to monitor that RPRs, just monitor what's happening in the blood. And what we do quite often see is that RPR does not always become negative. They call that a serofast state in about 50% of our patients. So some patients, they might have, preferably you want it to be lower than 1 in 8, but you get quite a lot that's like 1 in 4, 1 in 2, 1 in 1, and it just stays at that level, and that's acceptable. So then you're not looking for it to become negative, you're just checking that it doesn't increase. So now what do you do with somebody who's not responding? So either their titer is not reduced by 4, or you notice that titer is rising. So the first thing to do is just check that the patient actually complete their treatment. So have they had all the correct dosing and the correct times apart? The other thing to think about is reinfection. Are they sexually active? Has the partner been treated? Have they possibly been exposed? Are they using condoms? And it might be that they've actually been reinfected, and that's why the titer is not responding or has gone back up. Step 3 is remember that issue of the asymptomatic neurosyphilis. So these will be patients when you've excluded all of that, you've done all of that, your patient's asymptomatic, but that titer is just going up. You might actually have to LP them to make sure they don't have asymptomatic neurosyphilis. And then lastly, if that titer is rising or remains, oh, that's the one. Yes, sorry. My step 3 and 4, I'm not looking at my slides, I'm looking at my audience. So step 3 is if they've got symptoms of neurosyphilis, do an LP, obviously. And then step 4 is in that asymptomatic patient, if that titer remains high or is rising, consider doing an LP and looking for asymptomatic syphilis. So if none of this is present, if the patient's all fine, actually, and the titer is, so then you're going to repeat your RPR 3 to 6 months later. And then if the titer is not rising and it's 1 in 8 and lower, then we'll just keep an eye on them. So thank you very much. So in summary, that's the code for the actual guideline that you can scan or you can go and look up. It's on the HIV Clinician Society guideline. I think for me, the main takeaways from this is that we should start doing RPRs in any patient that's presenting with an STI, in any patient that's got a weird rash or a weird neurological or a weird eye presentation, and be very vigorous in following up whether we've actually treated those patients successfully. And that will hopefully get us to the point of eradicating congenital syphilis by 2028. Thank you very much, everybody. I'm now going to open it up for questions and comments. If you have a question, please put your hand up if you're online. Is there anybody here from the, we're broadcasting from the Family Medicine Boardroom. Anybody here who's got comments or questions? That was a lot of information. Hey? Come forward. Yes.
I just have a question about the RPR titer, and is it related to your risk of developing neurosyphilis? So if you have a higher RPR titer, are you more likely to develop neurosyphilis, or is it not really?
Yeah, if I remember right, I'll have to double check that, but I actually remember something because we attended the launch of it, and it's actually not related. So that's the challenge. What's more important is your immune status, for example. So an HIV patient with a low CD4 count is more likely to get neurosyphilis. And it's not got to do with the actual load of the syphilis itself. It has to do with how your body is managing the syphilis. That's why the babies are so vulnerable as well. It's not too much to do with how much they're infected, but how much their bodies are able to deal with the infection. I am interested from the district if you guys have got these rapid tests in the antenatal clinics yet, or if there's any talk of those.
Hi, Madeleine. Yes, we do have the rapid tests. There have been a few times when they've been out of stock, but they are generally available at the clinics. And they've also the dual testing kits they're also coming in. Yeah.
That's very exciting. And how's it going with the rollout of those? Does it feel like it's starting to be incorporated into our antenatal programs?
Yes, definitely.
Okay,
And
that's
I know some of the clinics are, because they've seen lots of syphilis, they, pretty much if anyone's presenting for an HIV test, they automatically do an RPR as well. And
That's
they've
great.
got high index of suspicion for, for doing rapid tests.
Very good. Yeah, and I think also, especially that guideline in August last year was very good in starting to prime our primary healthcare clinics. So I think this guideline is also great in terms of reinforcing that in private as well, to make sure that our private practitioners are also on board. Great, Dr. Carl.
Thank you very much, Dr. Muller, for this very useful topic. It seems we may easily miss the primary, even the secondary. There are so many differential diagnoses, and then you have to be very cautious, and you should have high index of suspicion. There is no doubt. And then in pregnant lady, we have to look order the RPR test so that but we protect both mom as well as kid. Regarding doxycycline, if somebody is allergic to penicillin, which true allergy to penicillin is very rare. In fact, small dizziness or tiny rash, that is not the contraindication. You have to get a very good history. If people get very bad pain, at the site of injection, they think it is kind of allergy that you have to really, Dr. Muller did specify it. One thing I would like to tell about doxycycline, especially in kids, it may stain the teeth. You see, that is one of the contraindication as well. In children, normally we don't prescribe tetracycline group, that is the doxycycline as well. That is apart from pregnancy. Of course, you have to plan for, for desensitization as such, and then I haven't seen many people being sent to the hospital or allergologist, for the desensitization as such, theoretically we talk about it. Anyway, that is my comment. Thank you so much. Thank you.
Yes, thank you very much. Yeah, I'm not sure also in terms of the desensitization, if anybody's actually ever done that. There is actually instructions in the EML, but yeah. Great. Any last comments or questions? Thank you very much, everybody. Have a lovely weekend while we're all waiting in suspense for the for the final results. We'll see you again at our next presentation in a month or two. Thank you.
Thank you so much, Dr. Muller.
Thank you.